What I'd like to talk about a little bit is where we're taking defining oligometastatic disease, specifically micrometastatic disease, to the lymphatic system and to the bone in an attempt to try to define in the most accurate manner possible where metastatic disease is in people who have already failed definitive therapy in an attempt to continue on a aggressive course of therapy aimed at chronic suppression of the disease. And I will share with you that this is a rather personal journey that started many years ago for me with my dad when he had metastatic prostate cancer, and was particularly vexing to me as a diagnostic radiologist, because despite the fact that he failed definitive therapy with radical prostatectomy, we couldn't find the disease. And then despite the fact that he continued to recur with rising PSA after rescue radiotherapy, we still couldn't find the disease. And despite the fact that he entered all of these clinical trials at Dana-Farber and at Memorial Sloan Kettering, for a long time we still couldn't find that disease. And by the time it was recommended that he go over to Europe to get a Combidex study, it was too late. He was too sick to get over there. And so it's something that was particularly vexing to me on a personal level, and for all diagnostic radiologists, I think, is very vexing on a professional level as well. And so I'm going to skip through the background of the demographics of prostate cancer, because you are all very familiar with it. But interestingly, we've had an interest in defining early lymphatic disease as radiologists, and personally with my dad for many years. And in 2003, Dr. Harrisangani, one of my colleagues up at Mass General, with a variety of other researchers from many institutions across the world, published what I thought was a rather seminal article in the New England Journal of Medicine, demonstrating the efficacy of Combidex in its ability to differentiate benign from malignant lymph nodes in patients who had recurrent or metastatic prostate carcinoma. And I thought that was going to be a true breakthrough in the delineation of micrometastatic disease in an attempt to define and hone the radiotherapy or other therapeutic options for patients with metastatic disease to the lymph nodes. Unfortunately, as we all are well aware, the FDA did not approve the drug as a lymphatic contrast agent. And in fact, the company that made the drug, AMAG Pharmaceuticals, out of Cambridge, Massachusetts, ultimately halted that production of that drug. That same manufacturer happens to make ferrimoxetol, or Ferraheme, which is an agent that did receive FDA approval, not as a lymphatic contrast media agent, but rather as an agent to treat iron deficiency anemia in patients who had dialysis-dependent end-stage renal disease. Turns out that Ferraheme has a molecular composition that's very, very similar to Combidex. It's what we call a superparamagnetic iron oxide nanoparticle. It's coated with a very low molecular weight carbohydrate. While it is administered through the veins, it is what we call a lymphotrophic agent, and what that means is that it is taken up by the lymph nodes on a well-defined and constant basis within the lymph nodes and throughout the reticuloendothelial system. So what that means is that it has a similar uptake and mechanism to Combidex, and it has iron in it. And from an imaging standpoint, we have, with increasing magnetic field strength with 3T magnets especially, the ability to take advantage of the fact that Ferraheme is taken up by lymph nodes and contains iron, and we can create sequences that allow us to cause a discrepancy between the lymph nodes, the normal lymphocytes and lymph nodes that take up Ferraheme, and cancer cells which do not. And so when Ferraheme first came FDA approved in 2009, I was approached by Dr. Michael DeToli and Snuffy Myers, both of them, both of whom had seen my dad when he was sick, and asked me if I had any interest in trying to define whether this could be as efficacious in the delineation of disease as Combidex, to which I vociferously and enthusiastically said yes. So we hypothesized that Ferraheme-enhanced MRI would be able to detect lymph node metastases with a high degree of sensitivity, specificity, and accuracy, similar to what had been shown in the paper by Harrison and Ghani in the New England Journal of Medicine. So we wanted to do this for the reasons that I sort of experienced on a personal level with my dad. We wanted to define as quickly as possible and at the earliest stage possible lymphatic metastatic disease. We know that the earlier we catch this disease, we improve the number of therapeutic options and the ability to hopefully eradicate or sterilize it on a long-term basis with durable remission with the radiotherapy or a combination of medicine and radiotherapy. And we thought that really what we might be able to do, and this is something that's believed in oncologic circles for many cancers now, is that we could define very accurately oligometastatic disease or focal localized disease that even while it was metastatic still had not spread throughout the body, and be able in so doing to convert treatment failures or people who just sort of had a shotgun approach to their treatment into long-term survivors or durable remission survivors. So we created sequences with the MR that took advantage of the fact that there's iron in the ferroheme. And these sequences, what they do is they take all the cells in the lymphatic system, the lymphocytes, that take up the iron or the ferroheme, and they cause all those cells to turn black. And those same sequences have the ability to turn fat black as well. And in a paradoxical fashion, those same sequences tend to turn prostate cancer cells, and many malignant cells, in fact, bright. So against this very dark background of normal fat in the body, a dark background of normal lymphocytes in the lymph nodes, abnormal bright signal coming out of those lymph nodes, we hypothesized would be abnormal cells, and hopefully we'd be able to prove in the setting of metastatic prostate cancer that they would be prostate cancer cells. So this is an example of, I don't know if it does show, good. So this is an example of well-defined lymph nodes on contrast-enhanced MR. They demonstrate homogeneous enhancement, and they're very well defined against this sequence, which also has the ability to turn the fat black. On the ferroheme study, after the administration, this was just in a normal subject, after the administration of ferroheme, when we use those same types of sequences called a T2 star sequence, you can see that those lymph nodes blend right in with the fat. They look just completely black. That's what we anticipated that they would do because they're normal lymph nodes in a normal volunteer. We hypothesized that this would occur throughout the body, that it wasn't just going to be in the pelvis or in the abdomen or the chest. And again, these are just examples of lymph nodes here in the chest, an axillary lymph node demonstrating enhancement with the post-contrast, and then on the sequence that's specific to detecting ferroheme, it turns nice and dark, and it's a normal lymph node. So over time, we were able to recruit over 150 patients who met the biochemical definition of metastatic cancer as defined by biochemical recurrence or increasing PSA after definitive treatment, be that radical prostatectomy or brachytherapy or IMRT or a combination of any of the three above. And all of them underwent ferriomoxetol administration. The ferriomoxetol administration, we sort of mimicked from the Comodex experience in that it takes a little while for the vascular administration of the drug to get into the lymphatic system. And over time, we scanned all of these patients and determined that after about 12 hours, you get very good lymphatic uptake of the ferroheme, and that persists over about 24 to 36 hours. So we standardized it so that we administer the drug day one, and then the next day we do the MR scanning. We had 3 minor complications. They weren't really complications, they were adverse drug effects. 2 of them were similar to the drug effects that we get from iodinated contrast media with CT, which was an allergic reaction of similar to asthma with a little bit of itchiness and hives, or that required IV saline and Benadryl. And one of them was another reaction similar to what we can see with iodinated contrast media on CT, which is called a vasovagal response. All of them easily treated with standard therapy that we use in any outpatient radiology suite for treatment of CT contrast or MR contrast reactions. And then they underwent MR imaging with the T2 star and T2 medic sequences, which are the sequences specific to the ferrochem, and then the studies were independently reviewed. I'm going to skip this for the sake of time and just go to a couple things to demonstrate that we sort of took patients across the patient population spectrum who had radical prostatectomy or brachytherapy or external beam radiation or both. The mean age was a standard mean age for prostate cancer with a range that was significant over 40 years. All of the patients that we took in this cohort of populations had rising PSAs after definitive therapy, therefore met the standard definition of metastatic disease. And all of them were on top of that receiving some sort of medical oncologic management as defined below, a combination of the above. Our imaging workup typically utilizes 64 slice CT and 3T MR. And the reason that we use 3T is because there's a large field of view that we want to cover. It's relatively rapid acquisition. We're doing a lot of sequences because we do a standard MR of the abdomen, pelvis, and sometimes the chest. And on top of that, we're doing definitive additional sequences to define the ferrochem administration. We want high resolution so that we can see lymph nodes down to 3 or 4 or 5 millimeters. The whole goal is to try to be as specific and sensitive, again, to lymphatic invasion, and so we have to be able to delineate small lymph nodes or a large field of view. And and probably the most important is that we want homogeneous T2 star and T2 medic sequencing so that the whole field demonstrates the appropriate suppression of signal that we anticipate, and that is easily attained with a 3T magnet. So of the patients that we imaged, 27 of them demonstrated lymph nodes which were abnormally bright on the medic or the T2 star signal. 7 of them demonstrated lymph nodes in the retroperitoneum, which is in the area of the abdomen surrounding the aorta. A couple of patients, surprisingly, demonstrated failure of suppression up in the mediastinum. And we also had patients who had abnormal lymph nodes going all the way up into the neck, which is considered relatively atypical and rare in metastatic prostate carcinoma. Of those lymph nodes that we defined as abnormal, 84 of those lymph nodes went to rad path correlation, where we did either ultrasound-guided or CT-guided biopsies. Of those 84 lymph nodes, 76 demonstrated metastatic prostate cancer. 2 of them turned out to be lymphoma, and 6 of the 84 that we thought were going to be abnormal and have prostate cancer in them were considered normal on pathologic evaluation. So the importance of this is that classically, you can't call a lymph node abnormal until it gets to be a certain size in all dimensions that you measure it. And for classic characterization, it typically is 1 centimeter in every which way you measure it, top to bottom, side to side, front to back. And the most important part about this is that of the 84 lymph nodes that were defined, 39 of them would have been called normal using classic CT or MR criteria for being, cancer or non-cancer or abnormal lymph nodes. So a full 47% of the lymph nodes did not fulfill what we as radiologists use as traditional imaging criteria for malignancy. That's a huge number. That means that 50% of the cancer that we discovered using the ferrochem in the lymphatic cells would not be reported on a standard CT or MR report using the tools that we have had up to this point to define metastatic disease to the lymph nodes. So I'm just going to give you an example of what that means and how we delineate it and what it means for therapy towards the end of this talk. So these are examples all throughout the body and oftentimes in many places of the body where we don't classically think lymphatic disease of prostate cancer is going to actually end up being, but they surprised us in a couple places. So this is an example in the left axillary region underneath the pectoralis musculature of small little lymph nodes seen on CT. demonstrate. Standard enhancement on MR really doesn't help us all that tremendously in delineating benign from malignant disease just by the enhancement characteristics. Yet surprisingly, when we did the sequences that should suppress all the normal cells and lymph nodes, all of these lymph nodes turned out to be bright, and this patient underwent ultrasound-guided lymph node biopsy, and the histopathology was metastatic prostate cancer. So these are other examples of the same thing. So you can have in the mediastinum again a mass demonstrating bright signal, lymph nodes in the pelvis, which also demonstrate normal bright cell enhancement and demonstrate bright abnormal signal on the Farahim study, which also went to biopsy and showed prostate cancer again and again and again. So what's the importance of this? Well, and one last thing is that now we also have pelvic diffusion, which is a non-contrast way of trying to delineate that as well. So that's in the future, and we may be able to avoid even Farahim just by looking at diffusion coefficients. But our conclusion was that the lack of suppression in these lymph nodes highly suggests lymphatic dissemination metastatic disease and prostate cancer. And instead of having to rely on size criteria of 10 by 10 by 10, we could go down to a focal resolution of about 3 millimeters. It's hoped that the adaptability of this will help to further delineate early lymphatic metastatic disease and yield far better survival with appropriate radiotherapeutic intervention. So the clinical relevance is that we took a lot of these patients to radiotherapy. And the result very quickly was very interesting. So you have to wait about 2 years after the hormone effect wears off to delineate any kind of true treatment success. So 16 patients had a greater than 2-year follow-up. Of those, 13 had durable remission of the disease with stable suppression of the PSA. 2 had slow rising PSA, and only 1 had rapidly developing PSA, and that was from osseous lesions. So that's the good news. We think that this is helping to shift the paradigm in the ability to define oligometastatic disease so that we can define appropriate treatment, and the appropriate treatment, at least in the short term, it looks like that it's being successful in helping with durable remission. The one bad thing that I just want to end with is that a black box warning has just been announced for Farahim. Black box warnings have occurred for everything under the sun, including the standard contrast agents that are used for MRI right now. But we are awaiting guidance from the NIH and other academic institutions as to how we're going to proceed forward with that and manage some anaphylactic reactions, which occur on the average about 50% more commonly than with CT guide. But we're using pattern recognition, and even with pattern recognition, now that we've done so many patients, we have an 80 to 85% concordance with Farahim. So we see a silver lining in all of this. We think that this is going to proceed unabated, and that it's going to help us with earlier and more appropriate intervention that yields more durable long-term suppression of the PSA. Thank you very much.
So I'd like to thank Tom and Chuck and all the organizers of ASTU to invite me here to give this talk. It's a real pleasure. I've been involved with some other activities of ASTU, and it's always a pleasure to meet with the patients and with you guys. So first, I'd like to very briefly talk about the problems and needs, how MR imaging can help. And then I just heard the discussion at the panel about multiparametric prostate MRI. One of my goals here in this next 30 minutes is hopefully to clarify what is multiparametric and how MR works for prostate. We'll briefly talk about the indications of MRI in prostate cancer treatment, and then we'll finish up with targeted biopsies. And last topic I want to talk about is image-guided focal therapy, which is really an exciting and promising new paradigm for treatment of early prostate cancer. So as Dr. Bravo mentioned, this group is definitely well educated to know about this. And we are very aware of the stage migration in prostate cancer, which has led to diagnosis of cancer patients with younger age, with less volume, and an early stage. And there are two problems that MRI can help currently in the management of prostate cancer. One is the inefficient diagnosis, and the second is over-treatment problem. If you look at the inefficient diagnosis problem a little bit more closely, we do about 1.2 million prostate biopsies every year in the US, which costs quite a bit of money, but yet only about 30% of the initial biopsies is positive. And the remainder of the patients, as you very well know, are not quite sure whether they have cancer that was missed or it was just a false positively elevated PSA. And over the years, there have been large population studies which has shown either no significant or maybe slight improvement in mortality. Another problem is the biopsy-based Gleason score, as we all know, is not reliable and is upgraded about 30% of the time if the biopsy is repeated or the patient undergoes prostatectomy. Well, that in effect leads to flawed management decisions. I think today everybody agrees that there's an over-treatment rate of about 27 to 56%. That's quite a number. And probably 30 to 40 prostatectomies need to be performed to save one patient's life. And those procedures, either prostatectomy or radiation, as we know, are not really free from complications. In fact, about 1/3 of the time, they can be affiliated with some complications which may affect quality of life. And this U.S. Preventive Services Task Force recommendation really had a huge impact in the management. And the U.S. Preventive Services Task Force recommended against PSA screening, but also they mentioned that PSA screening does more harm than good. Well, there are people out there which do not agree with this decision, but certainly there's a lot of say on the reimbursement of the various tests, including PSA tests. And interestingly, prostate cancer, if you look at it, is one of the few cancers that we do not use imaging at all for its diagnosis or for local staging. And MRI is currently the best non-invasive imaging method for prostate, and there's clearly a need for a better diagnostic algorithm. We know that there are some competitions on the genomic side. There are various biopsy-based or blood-based or urine-based tests that are coming, but certainly imaging, there are certain low-hanging fruits for MRI that can change the, or that can have a big impact today in the management of prostate cancer. So if you look at the evolution of prostate MRI, this is how we started about maybe 30 years ago. You look at the image quality back then and look at the image quality now. This is a prostate, a coronal view. These are seminal vesicles. This is an exquisite detail of the prostate that you could see. And we certainly came a long way to better understand the look of how the prostate cancer looked like on MRI. I want to briefly show you the anatomy of the prostate because we talk about prostate, but I'm not sure how well informed we are about the anatomy. So prostate is divided into zones. And this T2-weighted axial image, transverse image to the prostate, shows these zones very clearly. So this more white part here is the peripheral zone, where about 70% of the cancers arise. Luckily, the normal peripheral zone is very dark, as you see here, and any kind of cancer here appears peripheral zone is bright, and any kind of cancer appears dark in this peripheral zone, which make our job much easier. This is the transition zone, which about 30% of the cancers arise. And this is a problematic area for us, for radiologists, because as you see, it looks very chaotic, even when it's normal. This is where most of the BPH arise from, and only 30% of the cancer arises from, and this is a current area of struggle for us to identify cancer from BPH in this zone. Here's a coronal view of the prostate, which is kind of head to toe. This is closer to the head. This is closer to the feet. And these are the seminal vesicles that you can clearly see. So let's talk about the multiparametric MR protocol. I know in the last panel, the speakers alluded to it. So multiparametric MR protocol is widely embraced today in both sides of the Atlantic and across the world, basically. What it is it's made up of multiple sequences. The most important sequence is the T2-weighted fast spin echo sequence, or T2-weighted sequence, where here you can see the exquisite detail in prostate. The second most important sequence is diffusion-weighted imaging. Here, the contrast here comes from the imaging the ability of water molecules to move around. So in mediums such as cancer, where water molecules cannot move as fast as they would in normal, you will see this bright signal on DWI images, which indicates the cancer. The third modality of MRI is dynamic contrast enhanced MRI. So we give IV contrast to our patients, and then we acquire these images, which enable us to give us some information about perfusion of the prostate. So these three are combined in one prostate MR protocol in most centers, including ours, and this is called multiparametric MR protocol. We used to do, and previously, like many other centers, we used to do MR spectroscopy, but now this has really fallen out of attention. It is a very long sequence, and its added value to the other 3 sequences is very controversial. So that's why, like in our center and most other centers, we focus on T2 weighted imaging, diffusion weighted imaging, and dynamic contrast enhanced MRI. A couple technical points which may relate to us as patients as well. Patient preparation is important, and one of the most important things is to wait enough time after biopsy, because if there's biopsy recent, then there's a lot of hemorrhage in the prostate which may mimic cancer. As you see here, there's a dark spot. This mimics cancer, but actually this was just hemorrhage from the previous biopsy. So we wait at least 8 weeks before we do MRI after biopsy. Another still a question about MRI, should we use the coil, endorectal coil or not? This is how a coil looks like. It's actually pretty soft, plastic outside. It has a little antenna inside. And the reason we use coil is this antenna inside, this plastic rubber, collects the signal from the area that we want to image. And the closer it is to the area that we want to image, the better signals we get. So if, as you can imagine, the antenna is right here, prostate is right here, so we get way better signal. So this is a patient that we scanned with the coil, and here is without the coil. So image quality can be comparable, but there's no doubt that if you use endorectal coil, you get better images. But if you have a 1.5 Tesla scanner, then I think there's no doubt that you should use the coil. But if you have a 3 Tesla scanner, it's, I think, optional. In our center, we have 3 Tesla scanners, but we still use the coil to get the best out of the examination. This may change in the future, but so far we've always performed prostate MRIs with this endorectal coil. So here is how a prostate cancer would look like on a multi-parametric MRI. T2 weighted image, it's right there in the center, it's dark. Diffusion weighted image, it's bright. This is a different processing from DWI images, which is the ADC map, it's dark. And then on the dynamic contrast enhanced MR images, it enhances earlier, way earlier compared to normal prostate. This is how a normal prostate cancer would look like. If every prostate cancer read the book and looked like that, actually our job will be much easier, but unfortunately that's not the case. There are some pitfalls that we struggle every day. So if you look at this case, on T2 weighted image, both sides look dark. And on the ADC, only on the ADC image you can see the cancer on the left side. But the right side, again, this is hemorrhage, so that's why we don't want to scan the patients too early after the biopsy. Prostate cancer is really a very tough cancer to image. We struggle. I reviewed a couple hundred prostatectomies with our pathologists together with their MR images side by side, and that certainly taught me a lot, and also was a very humbling experience. This is one of those cases. So I was reviewing this case with my pathologist, so I could see the cancer on the right side of the peripheral zone, dark on T2, dark on ADC, enhancing early. I was very happy with that, and that was confirmed. But then my pathologist told me the left side was also full of cancer. So when I look back, even I can't see. So that's a subtype of a prostate cancer, which instead of forming a mass, it just sneaks into the normal prostate. And currently, we are very limited with MRI in detecting these type of cancers. The good news is most of these cancers are Gleason score 6 cancers, as was discussed in the previous panel. They are low-grade cancers, but this is just an indication that we can't see all of the cancers with MRI. If you look at the transition zone cancers, again, that's one area that we struggle because normal transition zone can look dark. But by using multi-parametric MRI, we try to do our best in identifying the large transition zone cancers. I want to spend a couple minutes on anterior tumors. These are important tumors. They are in the front part of the prostate, and they are often are not sampled with regular truss-guided biopsy. The needles typically do not reach that front end of the prostate, and this is the area where most cancers are missed despite multiple ultrasound-guided biopsies. So if we do an MRI for a patient who have elevated PSA but negative biopsies, this is an area that we very carefully check. As you see in this case, there's a very large anterior tumor, dark on T2, dark on ADC, and enhancing early on DC MRI. Once you know where you look for, it's very easy to pick up, but these cancers are very commonly missed with regular truss-guided biopsies. So I want to spend a couple minutes on potential indications of MRI in prostate cancer. These are all potential indications. None of these have been clinically currently are validated, but yet we do MRI for almost all of these indications every day. One option is to do MRI after, in patients with elevated PSA before truss-guided biopsy. There are only a few maybe academic centers which apply this in US. In Europe and in other parts of the world, this is becoming more popular. But again, we don't have clear data to validate this approach. Another approach is, which we have more data, is to do MRI after the initial truss-guided biopsy. Now, I think there are several single-center studies as well as a very large cohort from NIH that was published in JAMA recently, which shows that these targeted biopsies really increase the yield. So what happens is the patient has elevated PSA, undergoes a truss-guided biopsy, which is basically a random sampling of prostate. If biopsy comes negative, we do MRI, and then we repeat the biopsy with targeted MRI, either MR-guided biopsy that I'm going to show you towards the end of this talk. Another indication for MRI could be for the patients who have diagnosed prostate cancer. We can do MRI to better understand the tumor volume for staging, which in effect hopefully will lead to more educated, better treatment decisions. Because as you know, the treatment of prostate cancer varies from prostatectomy to active surveillance. And certainly if we have more information about the tumor volume, we can make better decisions. There are lots of new papers coming out for use of MRI in triage and follow-up of patients with active surveillance. And also, definitely, if you want to do focal therapy, you want to know where the cancer is. Again, MRI is very important for that purpose. And another potential indication for MRI is for patients with rising PSA with biochemical recurrence after therapy. So this used to be the classic indications for MR detection and local staging. Now, the evolving indications in the last decade are using MRI for targeted biopsies, follow-up and triage of active surveillance patients, focal therapy, detection of recurrence, and a lot of research is going on to use MRI for risk stratification to understand the volume and aggressiveness. So this is a patient with known prostate cancer. We do this MRI for staging purposes. Here on the right side, you could see the cancer, but also you can see that the capsule is coming slightly outside of the capsule. And you can see it on all these multiparametric MR images. So this could be helpful for the surgeon. While the surgeon is doing the excision, he can have a much wider excision on the right side, whereas he could go very close to the prostate on the other side. This is a patient, again, with known prostate cancer. We did multiparametric MRI. We looked at the seminal vesicle invasion. MR seems to be doing very well in detecting seminal vesicle invasion, in this case on the right side of the prostate, which directly affects the staging of the patient, and also potentially treatment decision. This is another case. So there's a large cancer possibly going out. Still, the patient can be a candidate for surgery. But if we see a metastatic lymph node, as Dr. Bravo showed in his excellent talk before me, then this really changes the patient management, and these patients usually are not candidates for surgery. So detecting either a metastatic lymph node or a bone metastasis on MRI is really critical and certainly has a huge impact on patient management. I want to say just a couple words about image interpretation just to make you aware of how we interpret these images. Currently, it's most centers, including us, clinical evaluation is subjective and qualitative. Many centers, including us, are working hard to make everything a little bit more objective and quantitative, but currently we are not there yet for clinical purposes. As Jen mentioned during the panel discussion, PIRAT's second version was released late December last year. Certainly, it's very helpful. It's a great step to standardize prostate cancer MRI interpretation. And many centers are now starting to embrace PIRATs to stratify the risk of the patient. T2 and DWI images are the most important sequences. We use some dedicated workstations while interpreting the images. As you see here, there's an overwhelming amount of data. It's almost too much for one radiologist to evaluate and analyze. So therefore, there's a lot of research going on to develop some computer software which help us to better analyze this data. And we also use structured reporting. This is just our sample report template. So this way, we aim to have a much better and much more standardized communication with our urologists, radiation oncologists, and medical oncologists. So I want to say a couple words about computer-aided diagnosis. Here in this case, softwares help the physicians in their diagnosis of the cancer. And also such computer-aided diagnosis tools can certainly improve the standardization of the image interpretation. This is a study that from our group. These are all computer-derived parameters, so no radiologists are involved in this image analysis. As you can see, these features can do a pretty good job in differentiating cancer from normal prostate. This is certainly an exciting area which can significantly improve the ability of MRI in changing prostate cancer management. In the second part of my talk, I want to briefly talk about how we can use MR information to improve diagnosis of prostate cancer and maybe even treatment of prostate cancer. So currently, there are three ways of using MRI to do targeted biopsies. One is MR-guided biopsies, which means basically putting the patient into the MRI and performing the biopsy in the MR scanner. The second one is MR-directed biopsy, or a fancier name for that is cognitive registration. On this one, we basically make our report, and then we somehow communicate the result with the urologist who does a trust-guided biopsy, and the urologist reading our report and comparing our images, they perform the biopsy. And the third one is the MR ultrasound fusion. So this is the device that we use for MR-guided biopsy, and this is one of the patients, 67-year-old with elevated PSA. Here's the cancer. This was a patient with a negative trust-guided biopsy. This is the device. This is a rectal needle sleeve that we put in. And then with the help of the computer, we can calibrate this rectal needle sleeve in 3 dimensions. And then once we are happy with the location, we just get 2 or 3 cores, which in this case shows Gleason score 6 cancer. This is another patient, 49-year-old with elevated PSA. 4 negative trust-guided biopsies, including one saturation biopsy. We did the MRI. There's a tiny cancer anteriorly here on the prostate. Again, 2 or 3 cores show the Gleason score 6 cancer in this patient. The second way, which is very commonly used, including in our center, is MR ultrasound fusion. In this algorithm, so the patient undergoes MRI, and then the images are sent to the workstation, and then we map the prostate, we map where the lesion is, we send the information to the urologist, and the urologist can fuse the MR images over ultrasound and then obtains the cores under ultrasound guidance with fusion with MRI. The third option, as you can see in this case, is this is one of the patients who was undergoing active surveillance. This is December 2012. There was a small cancer here. PSA was low, and only 1 core was positive, and only it showed Gleason score 6 cancer. Possibly this was missed. Oncotype DX showed a low-risk cancer score, so this patient went active surveillance. And the patient came back in February 2014, the mass significantly has increased. So we did MR-directed biopsy. Urologists performed the biopsy while knowing where the cancer is, and this time it showed Gleason score 9 cancer. So again, MR-directed biopsy is also a huge help for targeted biopsies. The last thing I want to touch upon is focal therapy. It's kind of a middle ground solution. It's an emerging paradigm. So currently in the United States, if a patient has localized prostate cancer, it has 2 options, either whole gland therapy or surveillance. Focal therapy is kind of a middle ground solution which offers both eradicating the cancer, sparing organs at risk, in this case the neurovascular bundle, rectum, and bladder, and also doesn't burn any bridges. So if any retreatment is needed, it also keeps a door open for retreatment. In our center, we have experience on MR-guided focal laser ablation. We use a perineal approach. So the patients are, this procedure is performed under conscious sedation. It doesn't require general anesthesia. We put this template into the perineum of the patient. We identify the target. We put our needle in. And then under real-time MR guidance, we can monitor the temperature. Once we are happy with the needle position, then we turn on the laser, and we know exactly where we are increasing the temperature and how much we increase the temperature. So this is very important. And then we can also get real-time information about the damage estimate. And this is post-ablation sequence, which shows the area of non-enhancing area in the previous area of the cancer. And this is the coronal image. So we did a phase 1 trial in 9 patients. It seemed to be a safe, feasible procedure. Then we moved on to a phase 2 study with an NIH grant. And again, the results look pretty promising, but the follow-up is only 12 months so far. But based on the promising results, we are now offering this at the University of Chicago as a clinical standard of care procedure with our urology colleagues. This is a network, international network on focal laser ablation that we are a part of. And like I said, now it's a clinically available procedure based on our promising phase 1 and phase 2 data. In conclusion, I hope I could convince you that MR can address the shortcomings of diagnosis and treatment of prostate cancer. Multiparametric MR protocol, which means T2, DW, and DC, is commonly embraced. And MRI is now commonly used for targeted biopsies and focal therapy. And it's a very new and exciting field. And if you like to have more information about prostate MRI, this is our website, and here's my email address. I'll be happy to respond to your questions. The last thing I want to leave you here is that we are very excited that we are going to organize an international prostate imaging symposium here in Chicago. A number of experts from Europe and also from United States already confirmed that they'll be able to attend this meeting. So we really look forward to having this meeting in Chicago, and we appreciate your support. Thank you.
So how exciting is this? Let me ask you just the first kind of naive question. What's the difference between what you described, what you do in Florida, and what I heard as sort of different areas of imaging? What's the quick answer to that one?
Well,
Are you a subcategory in essence?
Well, I think what Dr. Otto does is the first stage of imaging that needs to be done in any patient who is diagnosed with elevated PSA and there's a clinical concern for prostate carcinoma. Multiparametric imaging clearly is state-of-the-art and helps to define the disease the way no other imaging or intervention, including truss or any other kind of biopsy blindly done as it's been done for years can. So he is clearly on the study, Dr. Otto is clearly on the edge of technology and the cutting edge of technology that defines prostate cancer the way we've never been able to define it before at the level of the gland and the prostatic fossa, including the seminal vesicles. What I do is for those patients who have typically been treated and have failed that definitive therapy after having been diagnosed appropriately with multiparametric MR imaging.
So I think it's pretty complementary what we do exactly.
Yeah, exactly.
So, and if I also understand what you're saying, you're really looking at the nodes, right?
We're not looking at the prostate fossa at all, except for recurrent soft tissue masses. That's correct.
And the people I know out there in the audience, like past board member Dave Houchins, found this very helpful, finding your cancer, right? With Combidex, that's right. And that's when you used to go to Europe, right? And we fought that battle but lost, didn't we, about using Combidex?
Yeah, 10 years ago.
Yeah. Let's spend a little time with questions. Jerry, I'll get the microphone to you.
Dr. Bravo, are you only working with nodes? Do you find, does what you're doing light up, for instance, if you've got a typical or an atypical metastatic cancer to the chest or to the lungs, or is it only node related?
Yeah, this is geared predominantly to the lymphatic system, the reticuloendothelial system, which is the liver and the spleen as well. Those are the areas that the Faraheme addresses. Now, as part of our comprehensive evaluation to determine to the greatest extent possible where the metastatic disease is, we also combine the Faraheme MR with F18 sodium fluoride PET-CT bone scan to evaluate contemporaneously for osseous metastatic or bony metastatic disease as well.
And then how...
And the CT itself is very, very sensitive to the detection of, for instance, pulmonary metastatic disease, mets to the lungs.
Right. So now how is this used in connection with treatment? Talk a little bit about the transition. Once you find these places, what's done? What can be done?
Right. So similar to what Dr. Otto does with the urologist and helps them to actually see and visualize the tumor and then translate it into the modality that they use for biopsy, we do the same thing with our radiation therapists. So what we do is we define or delineate the small little lymph nodes, and we reproduce them in a three-dimensional model. We tag them, we mark them, and we actually have them available on our over our portal, and we actually ship it right into their website and their portal over a secure VPN line, so that they could, the same 3, 4, 5 millimeter lymph node that I'm describing, they can localize to within a millimeter or two, so they know that they're targeting the lesion that I've discussed in my report.
Craig, let me get down there to you. Yeah, yes, please. You're so articulate. We don't want to miss it.
That was a setup. I was a patient representative on a panel down at the AUA on partial gland ablation last May, and there seemed to be a gigantic battle going on among the medical community about whether or not MRI imaging is good enough to do partial gland ablation yet. And I was wondering if you could comment on your opinion on whether that's going to happen. There was a discussion there that basically the patient said perfection is the enemy of the good. Can we get on with this? Obviously, it's too late for everyone here in the room, but I think partial gland ablation holds great promise for the cohort coming behind us.
No, absolutely. This is a good point. I agree with you. The jury is still out on that. I've purposefully shared some examples of cases that MR could not detect some of the cancers. So we are not really claiming that MR is perfect. But I think it's clear that MR is much more successful in detecting large lesions as well as higher Gleason score cancer lesions. So this might, in effect, actually be a good thing because missing some of those Gleason score cancers, which will not harm the patient, may not be that bad after all. However, even though rare, MR can sometimes miss some of the Gleason score 7 cancers as well. The proponents of focal therapy paradigm really relies on the index lesion concept, which basically means that even though their prostate cancer is multifocal about 80% of the time, there's only one focus which determines the prognosis of the patient. And that's the one which is the largest cancer and which is the highest Gleason score. And since MR can detect those much more successfully, I think MR may have a role in that. But as you mentioned, patient selection is very important. Currently, MRI alone certainly is not enough to select those patients. So we can combine MRI with either trust-guided biopsy or trust-guided random plus MR-targeted biopsies. This way we make sure that MR is not missing any significant cancer elsewhere in the prostate. And if that's the case, and we really feel comfortable about it, those subset of patients actually may benefit from focal therapy.
Dave first.
Dr. Bravo, I know that Dr. Berends is using Combidex again in the Netherlands, right. And I know he's reported, I believe, detecting nodes that are involved at small as 2 millimeters. I was just wondering how that compares with what you're seeing with the Farahim.
Right, we've detected nodes down to 3 millimeters right now. I know that he's detected nodes down to 2.
Let's go ahead.
Dr. Bravo, hi. Could you make a comment, compare the Farahim with either the C11 acetate or C11 choline PET CTs, please?
Right. So those are being used extensively for the same things that we're doing. The issue with those is the degree, the resolution of the detection of disease, which is still lower with the Farahim than with the C11. The other issue has to do with false positive findings. So some of the studies that actually were documented and used by the FDA to garnish approval of the FDA for that as a imaging modality had false positive rates of upwards of 35%.
Jerry?
Dr. Otto, I have some concerns I'd like to express about this focal therapy business. Number one, David Boswick years ago showed a wonderful slide where he mapped the prostate cancer that was in a gland and did genetic studies and showed that the very smallest lesion was in fact the one that had metastasized to the lymph nodes, not the largest lesion. So to base the therapy on the concept that the largest lesion is a sentinel lesion, I think does not have good scientific support. That's number one. Number two, the idea that you have a cancer that's not multifocal and so you don't have to treat all the other lesions, I think invites a lot of uncertainty. But most importantly, will we ever see the kind of study that would allow us to evaluate focal therapy in a legitimate way? Because right now, the people that are doing it are treating patients that don't need to be treated. So of course they do well. And I think that unless there's a prospective randomized trial, we will never be able to evaluate the value of focal therapy. Your comments.
These are all very legitimate concerns. And so Going back to the index lesion concept, it's not very widely, I mean, it's not completely agreed that index lesion concept works, but the cases that you mentioned, there are only a few case reports about this. So the evidence on the other side is not very strong either. Going back to the validation, I completely agree with you. I wish we could do a randomized study that would compare focal ablation with either active surveillance or radiation or prostatectomy. But as you very well know, these are very difficult studies to plan. And you may need to recruit thousands of patients, need to follow them for 10 years, 15 years. And there's a lot of discussion about how to do these studies. And it's really very difficult to fund those studies. So one maybe way to approach that could be registries. Like it was done in
But you know
Ukraine.
that registries are not valid for being able to evaluate and compare therapies. So, I mean, I accept the length of time that's needed and the expense. But for the public that's being guided into focal therapy even now, without any of that data or an attempt to gather it, how is the public going to be well served without doing the study that's needed, notwithstanding the difficulty of doing it?
Right, so we're one of the centers who really had tried to do the most scientific approach. So far, we haven't really charged any of the patients. We got the grants, so that's how we start with the phase 1 level. And then depending on the promising results, we moved to a phase 2 study, which was basically funded by NIH. It was a very scientific approach. And so far, I think at the phase 2 level, it seems very promising. But I agree with you. I wish we could do a validated study to see how well focal therapy does compared to the other treatment methods. I'm with you there.
All right. By my watch, it's time to move on. Again, we'll have people around to talk further about this. Let's thank our panelists for what I thought was a very good presentation.